Well, I want to welcome everyone. I am thrilled about this meeting today. Patti Robinson is definitely a pioneer in our field of integrated behavioral health. And you can definitely Google her or even look up PubMed, and you will see lots of publications and her work. For me, Patti is one of the people that has been a personal support to me as I've tried to answer questions, and she will respond on a listserv, or if I send her an email, she'll send me a very relevant, either an article or something that they've done in the past. And so she's been a trusted resource for me as I've learned more and more every day about integrated behavioral health. The other thing about Patti, and I don't know if you'll be able to pick this up being on Zoom and with 2 hour time difference, but if you meet her in person, she's one of those people that has an energy that you know that she is a real, true, authentic person who is full of compassion and authenticity. And I have felt really connected to her as a person. And when she and Kirk have done a lot of the trainings and role plays, you can see that she has done this work. And she definitely writes the books and writes the research, but she's done the work, and you can see how that comes across as she's interacting with patients, clients, colleagues. And so the warmth of the type of person that she is, this isn't just theory for her. And so I am very appreciative of having her spirit with us today, as well as her mind and heart. Um, if some of you don't know who Patti is, she has been one of our pioneers in really, in many ways, creating the integrated behavioral health models and done a lot of the research in primary care behavioral health. The hmm. So she's published books, chapters on primary care, many articles, and also several self-help books. She's the president of Mountain View Group and continues to provide training and mentoring to many people in the United States, but also around the world. And you may talk about that some, Patti, in your presentation as far as other places that you've been teaching. And been a pioneer in teaching focused acceptance and commitment therapy in primary care, which has been instrumental in being able to have a model that works in brief sessions in primary care. So thank you so much for being here, Patti, and thanks to everyone. And I'll just let you take it from here, Patti. Thank you.
Okay. Well, it's an honor to let me see. I'm gonna look at all your faces here for a minute before I screen. Well, we have 23 participants, but most people don't have their videos on. So I'll look at Jenny and Caitlin and Patti. Hello, good morning. Um, so I'm here right now in Portland, Oregon. I have a small home here and a small home in Wheeler, Oregon, which is about a mile from the ocean on the Nehalem River by the Neahkani Mountains. And I've been spending most of the past year and a half there. It's just been wonderful. So when I come to Portland, I feel like, wow, I'm in the city. And it's so exciting to start to get back on the road and teach in person. I've just been doing so much virtual teaching, and a person that felt they could, an introvert had trouble talking on the phone, and for sure, presenting on the web was to an empty space was something I avoided. I now, I've helped create with Kirk an online course. I've, looked at little people all over the world. I have a training in Turkey coming up next week, and it's just become normal. So I'm making the transition to letting being out in the world and being with people become normal again now. So I'm going through that. It's amazing how we all adapt. But today, what I would like to do is just kind of tell you in brief, kind of the path I've been walking and related to the origination of the primary care behavioral health model. So very specific kind of walk I've been taking. And so um, I'll just talk you through that. So what I hope to do is keep it kind of interactive. Patty, if you can kind of look at the chat and let me know when I'm on a kind of a small screen, so it's hard for me to monitor both, but let me know when there are questions or summarize things if there are a lot of questions. And because it's so much easier, I think, to learn and kind of um, integrate information if you can ask questions as they kind of occur to you. So I'll talk about the context for the design and implementation of the first randomized controlled trials concerning delivery of behavioral health services in primary care. And those have had a big impact on how the field has developed. I'll talk about the methods and the materials used in those trials because we're still seeing them show up today and how they set the stage specifically for the development of both collaborative care and primary care behavioral health, the two dominant models in terms of integrated care at this point in time. I'll talk about the results of the randomized controlled trials. Many times people will hear one little snippet or something from a randomized controlled trial, and we all do that. We all run with that, and that's useful. But it's really nice to kind of see what were all the results and what can we take away from them even today to make our practice more vital. And then yeah, I'll kind of I'll encourage you to think about a new way of treating depression that really focuses not on symptoms, but on behavior, changing behavior. And that's kind of been um, my take on how to help people be the people they want to be in the world, is to help them with their behavior. Then I'll talk about focused acceptance and commitment therapy as an approach. And maybe I'll flip over to some brand new slides. I didn't have a chance to integrate them into the talk today, but they're from a publication last month by a primary care provider. So I'll pull those up at the end. So that means I should talk fast. So really 4 strands that we're going to talk about, but 2 themes really. Letting go of traditions. I think many times where our practices are steeped in traditions that we can't see. They just become the bubble we live in. They're the lens we look through, and we don't know we have glasses on. And if we're to innovate, we need to let go of some of these traditions and strongly held beliefs and convictions. But we need to hold on to science and really embrace science in a whole new way. So, kind of 4 phases, kind of a move from, in my life, from working in mental health settings to primary care settings into early randomized controlled trials, model development, and which is really a whole new thing. I've spent probably most of my life on model development and never intended to at all. I was a clinician researcher and just humbled to do that work. And actually, my first job was working in schools. I love working with children, but I love working with adults too. And then just talking about where we are right now with healthcare transformation and the opportunity to really change and better serve um, the people of the planet. So, um, this first theme of moving from mental health to primary care behavioral health really involves some giant steps, including moving from kind of this diagnosis and treat to target um, to care at the time of need for the problem. When I started my internship many years ago in the 70s in Kansas in student health, we had the DSM. It was a small book then. And it has grown, it's grown, and it really hasn't gotten any better. Oh, it's really a problem in terms of mapping to really helping us help people. We have a handful of treatments, and we have a book full of diagnoses. So another step has been about moving from this idea of intervening with the few, the people that were more severe, more symptomatic, more impaired, to a really broad outreach where we're looking at prevention, we're looking, of course, at acute care, but we're looking at chronic care as well. Um, and moving into more of a population-based care, of course, to do this. So treating a lot of people, giving a little bit of treatment to a lot of people in order to make this shift and to move from a traditional role of being a psychotherapist to being a consultant, where patients are much more empowered to make their decisions about when to seek care, when to stop care, and what works for them, what's the most important thing. So consulting with them about their lives and how they want to live them, and then consulting also with teammates, so working in a team kind of context. I'd like to acknowledge Donald Patrick, worked with early on. He was a real pioneer in terms of exploring population-based care. And he's was at the University of Washington Public Health Department. He was interested, of course, in primary care, and he was also focused on patient functioning, about quality of life. And so those were important themes for me to have as a young professional. Um, one of the things that we started looking at early on was, what do primary care providers identify? And with Donald Patrick, he was interested in the study that I worked with him that really influenced me the greatest. He was interested in patients over 65, and that's a really important population today. And some of his early work really should be informing what we're doing today, much more than it is. But the primary care providers at that time, they were really interested in treating depression and treating what they called the satisfaction with life and the ability to deal with stress. So we gave them different language to kind of respond to. And they could see that a lot of these people were just struggling with, the stresses of aging, which I better understand at this point. So it can lead to demoralization and have a big impact on that person's life, but also in the healthcare system, as we try to see one person at a time and deal with demoralization. That's not a very good model. So the PCPs didn't feel so well prepared to address this counseling. And so my job in this first study was to come up with a class that would help with these people that were depressed, demoralized, over 65. And so part of doing that was to go to the literature, look what has an evidence base. And Dolores Gallagher had an intervention that had been tested. It looked good, but of course it was much more intensive. It developed for secondary mental health. So we had to dose it for primary care, originally for 6 visits and then for 4 visits. And sorry, we have a puppy on the scene. And this is Mac, my very enthusiastic boy. So maybe he'll stay on the floor. Oh no. Anyway, we dosed it right for primary care. This is Miss Molly, 7 months old. And then we look at patient experience to, was this something that the people in primary care would value? And, they rated it very positively. These were people of all ages. And so, we lost people died and things like that. But they rated it very positively. In fact, of the 7 group interventions we tested in this preventive, this randomized control trial, of preventive services for older adults, it was the most positively evaluated. So we called this the life satisfaction class. So we named it to reduce stigma, and it was engaging, and many people participated in this. I taught this class over and over again in clinics up and down the I-5 corridor in Seattle, all the way down to Olympia, the capital of Washington State. So lots of experience in different primary care clinics, very helpful. But the one that was most instrumental was the one downtown Seattle, where I really started to make strong relationships because they had an older population. So I taught the class quite a few times there. So the goals of the class were to increase pleasurable activities, accomplishment activities, review problem solving, and look at new ways of working with depressed thoughts and feelings. And the medical chief of the Seattle Downtown Clinic, when I went to pull out, said, "No, wait, you can't. I'm talking to your chief. We don't. We need more than research. We just need you to stay." And because all of our patients need life satisfaction coaching from you, and in fact, my whole staff does. So he took his whole staff offline for a morning for 4 hours, and I taught them whole curriculum. And his idea was to make their lives more satisfying, but also to teach them the skills that I was teaching their patients so they could teach their patients. So there was a lot of model development in that relationship. And he turned out to be a co-author on the first book I ever wrote. So relationships, so important. And 3 years later, after that study, we developed a program to care for older adults, 75 and over, with multiple medical conditions that had to come to the clinic for at least once a month for medical reasons. And we developed a group medical visit. And I did this for 4 years. It was probably the most satisfying thing I ever did. I cooked for these people. It was rapid uptake among people. They evaluated it much more positively than usual care. We reduced in this medical group visit. We reduced use of the emergency department, and we had 100% advance directives. That's a big deal. You know, these people were not ringing up the healthcare system for $30,000 to exit the planet. So big deal. So, hey, look at me back when my hair wasn't gray. Um, I had that big bulky phone. Yes, we really did have these phones. And so after that study with Donald Patrick, Kirk and I were like, hey, let's try this. And so the four of us, Greg Simon, who is now the director of Center for Health Studies, or it has a slightly different name since Kaiser bought Group Health a while back. But Kirk Strassel, myself, Sue Snyder, we went out into clinics and we started seeing what we could do. But I did want to tell you the results of the study with Donald Patrick. And they are published, so you can look at them. It was a study where people were randomized, a large group of people randomized to this preventive services benefit package, you know, life satisfaction class, exercise, hearing, those sorts of classes, and compared to usual care, and then assessed at 24 months and 48 months after their enrollment. And the treatment group had more completion of advanced directives. They participated in more exercise, and they consumed less dietary fat than the control group. They also reported higher satisfaction with health, less decline in self-related health status, and fewer depression symptoms. So that's important. So if you work with a lot of older adults, take this away today. We continued to kind of like try to understand the primary care provider's perspective, because there's going to be forever many more primary care providers than there'll ever be psychiatrists or psychologists or social workers. And so we need to understand, what are they doing and what would they pick up on? And so we had a chance to do phone surveys with 155 people 1 to 4 months after a visit for depression, where they prescribed medications. And so they, interestingly, were doing some CBT. David Burns had written the Feeling Good book. People remember that by then. And PCPs are readers, they understand the suffering. People come to them on a daily basis with symptoms of depression. So these were the things they were doing. They were encouraging people to do what made them feel better, do more of it, to engage in pleasurable activities, problem solving, at the level that primary care patients could understand when we said the question. And not only that, but the PCPs who talked about these cognitive behavioral therapy strategies at the 1 month visit were using more CBT strategies at the 4-month visit. So not only were they doing them, they had an impact, a desirable impact on their patients. So we're also curious about, what's the context for people who get depressed and come to primary care. So 60% relationship problems, 48% occupational problems, 25% loss of a loved one, diagnosis of a health problem, 16%. Moving, very stressful. We're packing up this house because we're going to remodel. It's really great with my litter mates. They're helping a lot. They're destroying things as we move forward. So 7 months old. So lots of stress in these people's lives. And then we did the randomized control trials. They were in Seattle. And at the time, that context was ongoing tension between medication and behavioral health treatment, and what did depressed people need. And there was kind of a push to get primary care providers able to prescribe the new antidepressants as opposed to the old antidepressants. At the time, they had to fail an old antidepressant before they got a new antidepressant. So that was, and of course, at the time, we thought, oh, hallelujah, we have magical new antidepressants that will take a pill and make everything better. But of course, as a behavioral scientist, I knew probably not. It couldn't make that, unless short of LSD, and LSD is a very temporary state. Medications can help, but they rarely do everything. So it's always going to be single treatment, behavioral, or combined. So how depression looks in primary care. In our first RCT and our second RCT, we requested that primary care providers refer patients with probable major depression and willing to use the medication. So these are the people that were identified. And we did research diagnostic criteria interviewing on the same day or within a week. So we said, do they have major depression? Do they have minor depression? What do they have? And 58% and 57%, clearly the majority of the people referred were in that mild to moderate category. So these were patients that shouldn't be prescribed medication, but should get behavioral treatment first, because there wasn't evidence for medication working with more mild patients. But and then we had 42 and 43%. The analyses in both of the RCT studies are presented in these groups of mild to moderate and more severe, because there's some interesting findings to look at when you look at the difference between the two groups. So the first study is what we call the liaison psychiatry study, which best parallels the collaborative care model at this point. My job was to develop the the educational interventions materials content. So I wrote a booklet called 7 Ways to Cope and Using Medications Successfully. And then we did a video, and the psychiatry service, we didn't have a manualized treatment. So uh, they worked with patients individually, a wide range of number of contacts ranging between 1 and 17 visits. They monitored pharmacy records, and they provided advice on selection, dosing, adherence. So the patients received the booklet and the video at the time of the baseline interview, where they were randomized to liaison psychiatry. And then we collected data in telephone interviews a week later about the educational materials, because we really wanted to learn what would be helpful in the way of psychoeducation. And the good news is most read it. 75% read or viewed all of the educational materials, and the majority read them or found them as helpful. The video less so, and I think that's because with a problem like depression, if they read something, they're more engaged than if they watch a video. It's probably very easy to be in your head and just oh, do I look like that? Boy, I'm like that, so I don't know. Interesting to explore more on that. But these were just the ratings: 0 to 3, gold, 4 to 6, black, and the teal, 7 to 10. So this is an example from the 7 Ways to Cope. So explaining what pleasant activities are. These are things you do in your life just for fun. And then some instructions about how to increase your rate, and a request: bring this worksheet if it interests you to your visit with your next physician. So really setting them up to interact with their physician about behavioral activation, an evidence-based treatment, or a part of behavioral activation. Um, so what we found with this study is, in that mild to moderate category, we didn't get 50% reduction in depression on any of our measures of depression. We had 4, and we didn't move the dial on satisfaction with care. So that was of concern. We were successful with the more severe in these areas, so 42%, but clearly 58% we didn't succeed with. And this issue of getting better medication adherence, in hindsight, was not a good finding. At the time, we thought it was great, but it is great in the sense that it really emphasized the importance of adherence coaching on adherence from a behavioral point of view, because all of the adherence promoting techniques that we packed into that booklet are evidence-based. They're behavior. They're informed by behavior. So behavioral health consultants out there can use those principles to help people take blood pressure medication, truly something that can save your life. So look at it with that lens. So we wanted to improve going into our second RCT. Wanted to make it more acceptable to patients with mild to moderate symptoms, and more feasible, because resource-wise and cost-wise, we could never afford in this country all the people with depression in primary care. Mild to moderate are more severe to be seen by a liaison psychiatrist. Just not feasible. So the next study we called the Behavioral Health Consultant Intervention, and this intervention provided 2.5 to 3.5 hours direct consultation over a 4 to 6 week period. So these were half-hour visits, and We asked patients to complete 4 of these visits, and we had really high fidelity ratings. I think that's why we got the results, because we engaged people. Sometimes we saw them on the same day. They were randomized. We saw them within a week. We were in the clinic a lot. We worked closely with their PCPs in regards to the behavior change techniques we worked on. And we retained 94% of those that completed 1 visit, completed 4. So that's huge compared to what we do in our secondary mental health services. It's much lower retention. We also provided brief 5-minute calls over the follow-up period of 4.5 to 5 months. All of this was detailed in a 107-page integrated program intervention manual that I wrote, and we did fidelity ratings through audio tape, so there was strong adherence to that manual. Therefore, when we got the results, I was able to immediately turn that manual into a publication and get it out to the public. And that really, those publications and those presentations really have a big impact on people that can develop models like the United States Air Force, um, who bought lots and lots of copies of those first books based on the study. These are the, kind of the first 4 behavioral health consultant topics in those first 4 visits. Behavioral experiments, talking about 7 areas of life and improving quality of life in these areas according to the person's need. Daily pleasurable activities, problem solving, and new ways of working with thoughts and feelings. We had option of 2 extra visits, and 88% attended 1 or more of these, so they were engaged. These are the 7 areas of living, and these are the, you can have a look at the topics for optional visits that people selected because they could choose what they wanted. A lot of people wanted these were anticipating mindfulness kinds of strategies, focused acceptance and commitment therapy strategies. And a third of the people were like, yeah, I want more on that. And at the time I was already working, Kirk and I were already working with Steve Hayes. There wasn't acceptance and commitment therapy there, though there was comprehensive distancing. So we hadn't branded it at the time, but it's interesting that people were interested in that. So the goal of all behavioral health consultant visits was to work towards development of a behavioral experiment, and that's true in the focused acceptance and commitment therapy approach to delivery of primary care behavioral health services today. And that's what the calls were about. They were about the behavioral experiments. These are some of the features of this intervention: shared chart, feedback to PCPs with the intervention patients on the visits with the behavioral health consultants, suggestions of specific actions for the PCP to take with patients, written out just as they are in notes today, recommendations for the PCP. We had newsletters that we put out fortnightly, and we developed at the end of the patient's series of visits a relapse prevention plan. We called it a progress plan. And we really didn't do much training on this. It was mentioned in our kickoff meeting with PCPs, which was at the beginning of the study. And then it was just placed in the person's record and with a note, please support this at medical visits. The other part was the behavioral health consultant had brief weekly calls with a liaison psychiatrist. These were 10 to 20-minute calls. And we'd cover any kind of questions about medications and carry that to PCPs. Um, PCPs could talk with liaison psychiatrists. Patients could see liaison psychiatrists, but that was not necessary for most. 6% had a contact with um, liaison psychiatrists. So a much more feasible intervention cost-wise. Um, so same findings, or same table here, which shows on one of our 4 measures of depression, we moved the dial mild to moderate, and we got yeses for improved satisfaction and medication adherence. And that was true for both groups. The other thing that's like really interesting is we had a measure which looked at the rates of use of coping strategies that the behavioral health consultant taught. What were the patient's rates of using these pre-treatment and then at 1, 4, and 7 months? And I'll show you the scale, and I'll include in follow-up materials a handout you could use, which has this scale you could give to patients and they could rate it. And then you could have them choose one of the skills that they would like to learn. Um, and you can measure at follow-up, are they getting better at that, using that skill? Are they using it more frequently? So let me explain this graph just a little more. The green lines are the ones that got the behavioral health consultant visit. The black lines are the ones that got usual care. And the top green line and the top black line are the um, they represent the people with green is lower severity and black is um, higher severity. So higher severity is associated with using less coping strategies. So it's a behavioral kind of problem that we're looking at. Depression is. So we need to change the behaviors of people or help them change them. How can we do them? And can we change the behavior of people with more severe? And can we do it without medications? That is something we haven't evaluated um, clearly in primary care population, something that we need to, because we now know that medications are not a benign treatment. And for some people, they can cause secondary problems like emotional numbing. If you don't know what that is, look it up. It's something we should be evaluating, checking for when we find people that that don't respond to the behavioral interventions and we use medications to boost impact. We should be looking for that side effect and doing something about it if we see it. So these are the evidence-based coping strategies measured in the coping strategy use scale. And the scale is just not using 0, less than once a week 1, once a week 2, several times a week 3, daily 4. And you just add all of these up. It's very easy to use. So these are the ratings for treatment of depression, integrated program by mild to moderate categories. And you can see people were really positive about depression treatment. And now it's interesting, that was particularly true for minor depression in usual care. Like when you compare, that's like 55% good or excellent in usual care. These are people tend to have good relationships with their primary care providers versus 95% when augmented by the behavioral visits. And I have to tell you that usual care was a really rich comparison in these first randomized controlled trials, because it included not only seeing the primary care provider, but also being referred to the mental health service where they could access cognitive behavioral therapy individually or in groups, and they could receive medication consultation visits with psychiatrists. So that was usual care. They weren't restricted at all in terms of using secondary mental health. And this is the rates of using the relapse prevention plan, again, an evidence-based intervention and really important. So you see, again, not following is the black and following is the red, following a relapse prevention plan. And this was at 4 months. And what's cool here is that most of the people following the mild to moderate, they were following a relapse prevention plan, and that was true for more severe as well as mild to moderate. And then this graph is like really important because what you see here is whether this was, PCP and patient interaction. Did they see themselves as talking with their PCP about the relapse prevention plan? So were we influencing the conversation between the clinician and the patient? And that was true for mild to moderate. And what's really cool is for people that weren't in usual care, they were talking, about a third of them were talking with their primary care provider, which is the spillover effect, the generalization effect, the generative impact of just being there and working as part of a research study, putting relapse prevention plans in the medical charts. And PCPs, truly some of the smartest people I've ever worked with, are picking up on this and using it with the usual care patients, a great thing. So what are the components of the integrated care program that the PCPs saw as definitely useful, essential? So behavioral treatment, relapse prevention, and medication education. Oh, these are the essential. And these are our ratings from providers. 88% said materials were easy to use. 100% preferred integrated care program to referral to mental health. So it was really a home run in many ways. These were the books that resulted. And then I left my research team. Wayne Caton continued on at the University of Washington in the direction of impact. And for me, I was like, at that point, I'd seen enough. I was like, well, this has the potential to help a lot of people. And so I want to go outside the group health bubble. And because I had a strong interest in social justice. And so I went to a migrant health clinic in rural Washington state, Toppenish, Washington, and worked for the next 7 years with a group of wonderful primary care providers to learn as much as I could about implementing these kinds of interventions in team-based care in an area where there wasn't very much in the way of secondary services. So for most of our patients at Yakima Valley Farm Workers Clinic, there were no other services. For our children, there were some, but there were huge barriers to getting there because about 20 miles away. So there were 17 full-time equivalent providers there. We had about 4 in internal medicine, 4 in pediatrics, 4 in family medicine, 4 in OBGYN. So it was very rich. About 40% of the people I saw were under 18. And just a great opportunity to learn. And that's when I wrote the first books with Jeff Reeder, the first book on the primary care behavioral health model. So really the primary care behavioral health model was a clinician developed kind of model. So we made that shift from research to clinician focus. So it was PCP and BHC. What can we do that will work? And of course, farm workers received money from the federal government, from HRSA, to evaluate this program. It was evaluated independently by the planning department, so generating a lot of evidence for the model. And then I also started working with the United States Air Force. Actually, in 1998 was the beginning of their work, and when they picked up on the randomized controlled trials on depression. But I continued working with them for a long time, and still have close relationships. Jeff Ryder, my co-author on behavioral consultation primary care, was Air Force first, and they've just been huge leaders, so I'll talk about them. But I've also worked with public health departments and looked at how to implement this, and in homeless clinics, street youth clinics, schools, true in Multnomah County Public Health Department. And then I'll talk just a little bit this morning about a project in New Zealand. I'm so happy to tell you that yesterday, after quite a long process, I have passed all criteria and been requested to return to New Zealand as a critical health worker. And I now have reservations in managed isolation that will begin in mid-August, and then I'll be back down there to finish up countrywide dissemination of primary care behavioral health after some very exciting demonstration projects, including a national demonstration project that demonstrated health equity. So just in case any of you have to get off early, I wanted to let you know, hey, health equity, that's in terms of access and in terms of clinical outcome. We've got some mojo. It's not a finished thing. It needs to evolve and change and adapt to the culture and the setting, but there's some magic here. So yeah, my true north, I followed, and my teachers. The Air Force has been amazing. They've demonstrated things like 70% of patients treated in primary care behavioral health improve. It's true with people with greater severity as well. And this is patients receiving 2 to 4 visits. And improvement is in functioning, symptoms, and well-being. They've done one study looking 2 years out that suggested that changes are robust and stable. All of these are available. I have a reference list that I'll include in follow-up materials. And high satisfaction. One study on therapeutic alliance. I don't think we understand therapeutic alliance as a concept that well, but certainly in primary care, because it's a different context. It's not necessary that we have therapeutic alliance for people to improve. It's unrelated to outcome, at least in this study. And therapeutic alliance was rated higher for behavioral health consultants in a first visit. These are visits 15 to 30 minutes compared with secondary mental health initial visit, where the visits are like 30 or 60, 40, 50, 60 minutes. So some interesting, those of you that are interested in research, a good area to explore. And we see more and more randomized controlled trials looking at delivery of PCBH services to people with specific disorders such as post-traumatic stress disorder, suicidal ideation, sleep. So we have randomized controlled trials out there documenting the effectiveness of this approach for specific problems. In terms of system outcomes, we see large reductions in specialty mental health, more appropriate antidepressant prescribing. So people that prescribe too much going down. That was the case in at farm workers. Every year I was there, they were more likely to use a behavior change technique, less likely to prescribe. As I say, they learn very quickly. I think that overprescribing environment just occurred because we weren't there. We weren't there to help out. So PCP is more willing to engage with behavioral issues. Some really nice findings on suicidal ideation, and something we all should care about right now. Um, Patient and primary care satisfaction high, better utilization of primary care services. So primary care providers able to bill at higher rates for medical services when they're supported by a behavioral health consultant, and improved prevention, more able to meet their prevention outcomes. So now primary care behavioral health services mandated worldwide, all 75 clinics, and they use both collaborative care and primary care behavioral health. I helped them write manuals that describe both services. And what they have is they have a behavioral health consultant that's internal. That's the behavioral health consultant, internal inside the primary care clinic. And the one that's external, that's a prescriber, could be a nurse prescriber, or a psychiatrist, might be on their base, might not be on their base, but they're associated. They're in a mental health clinic, and part of their FTE is assigned to be available for consultations with the internal behavioral health consultant and the PCP, should they want to call and discuss the patient. Patients can be stepped up for a consultation with the external, but that would occur in the mental health clinic. They have integrated behavioral health consultants into their family practice residencies. So residents are trained to work with behavioral health consultants before going into their practices. And they did a study called First Stop, and they brought their four Charlies, which are like behavioral health consultant assistants. They brought them into primary care because they didn't have enough. Let's see, did I include they didn't have enough resources to meet the mental health needs of their population. And indeed, they had more people needing mental health services than needing medical services, and they didn't have more money. So they took people out of mental health, put them in primary care, and they told everybody, go to primary care for mental health, addictions kind of problems, accepting certain things, neuropsych testing, suicidality, homicidality, some military specific kinds of problems, and maybe people already established in mental health. But for the most part, go to primary care first. And with that, they saved a lot of money and helped a lot more people. So this is published too, but you can see they saw more patients, they saw more unique patients, and they saw patients they wouldn't have seen under their old integrated system, even though they had BHOP and they had primary care behavioral health consultants. When they enriched it and they asked people that were seen in primary care, would you have sought services from the mental health clinic if this service wasn't available? And what you saw, 30% definitely probably would not, 15% uncertain, so almost half. So really expanding the reach of behavioral health services. And many of these people without that service would be seeing their primary care provider and complaining of stomach aches, headaches, not feeling right, being tired, sleeping poorly. and getting medications or support in our examinations, procedures that are costly. Farm workers, just want to say a little bit about children. So here you see 67% of children improved, 33% stayed the same. That's something I'm very proud of. This is on the Pediatric Symptom Checklist. This is results in terms of adults with chronic disease. 67% improving in physical health, 76% in mental health, 62% of these Hispanic, 40% Spanish speaking. New Zealand, so these are the, I get to say this, 70% of Maori clients improved well-being compared with 71% overall. So 74% of Asian, 95% satisfaction ratings, very, very high. No difference in terms of rates of referral of Maori, Pacific Islanders, and Europeans referred for behavioral health most seen. We see the reducing prescribing of medication in favor of the skills before pills. 57 to 70% of patients seen for therapy on the same day, 75% within 5 days. We always ask in fact-oriented PCBH, is the client better, same, worse? And here you can, at a follow-up visit, here you can see in the New Zealand study, 62% better, 24% same, 14% worse. So improving or stabilizing 86% of patients seen. So these are just some studies that Jeff Ryder, Chris Hunter, others you'll see on the list. But PCBH and impact cut from the same cloth? I don't think so. But complementary, yes, I do think so. And we have things out there. We have practices out there. I've written about them. I think that primary care behavioral health provides a horizontal platform, takes all comers, tries to help everybody, every problem, every age. And then really impact fits in the primary care behavioral health model in terms of vertical integration strategies that really address the needs of a specific group of people, for example, depressed patients with diabetes. So there are challenges, there's lots of opportunities. I will send out this coping strategy use scale. You can have a look, see if you want to take it. I'm going to end with the poem. Two roads diverged in yellow wood, and sorry I could not travel both and be one traveler. Long I stood and looked down one as far as I could to where it bent in the undergrowth. Then took the other as just as fair, and having perhaps the better claim because it was grassy and wanted wear. Though as for that, the passing there had warned them really about the same. And both the morning equally lay in leaves no step had trodden back. Oh, I kept the first for another day. Yet, knowing how way leads on to way, I doubted if I should ever come back. I shall be telling this with a sigh somewhere, ages and ages hence. Two roads diverged in a wood, and I took the one less traveled by, and that has made all the difference. So in your journeys, I encourage you to follow your heart, do what matters, pay attention, fail mindfully, collect data, look for opportunities, and start again. Always start again if it doesn't work out. So thank you so much for your time. And yeah, I hope this is helpful to your practice. I can stay on for a few minutes if somebody wants to ask a question. Let's see, I see interested in understanding psychotherapist to consultant? Oh, yes. Addressing stigma and adherence, integration across continuum. Yeah. Okay. Psychiatrist to consultant. So in a consultant model, the primary care provider remains in charge of the patient. So you're making recommendations to the primary care provider. You're making recommendations to the um, patient. You don't have a caseload. You see people, at least half the people you see on the same day. You see them for brief visits focused on the problem of concern. You're not doing an evaluation of their life. You're not setting up a treatment plan. It's brief, intermittent throughout the lifespan in this consultation role. Um, and it allows us time to do preventive work as well as acute and chronic care kind of work. Stigma and adherence, well, by placing ourselves in primary care and working like primary care providers, we become a part of the team, become routine care. So we're nothing special. So primary care providers refer to us saying things like, I'd like you to see my colleague, Patti. She's an expert on stress, and I think she could be helpful to us today. Her visits are brief, 15, 30 minutes, and I think she'll have ideas for both of us. That really reduces stigma and shows a lot of respect. Adherence is all about, understanding, getting inside that person's mind and seeing what are their beliefs about medications. One of the most powerful parts of medications are placebo. So, I mean, do you have that going for you or not? You need to ask some questions to help you establish that. You also need to help the person develop some greater self-advocacy or self-efficacy for dealing with possible side effects. So knowing about them, having some skills to work with them. So there's a whole science towards, and then integration across care continuum. So for example, that Air Force study, the first what it is the patient, maybe the patient with the more severe kinds of problems, challenges, starts to work are through the behavioral health consultant and primary care provider, their team, getting a little information from a psychiatrist. And then if there's a need to step up, they just step up very briefly. They know that person, but they know who their team is. And the psychiatrist knows who their team is, so they don't hang on to them. They do their job of educating, empowering, upskilling that team to better serve the patient. Hope that helps. Let's see. And oh, good. Thank y'all. Thank y'all. I see other dogs and kitty cats. And here we have the great Mac Puggle, who's coming on to say goodbye. Is
Patty,
yeah.
It may be a question for another day, but
Yeah.
it's very obvious to me that you make the distinction in the evidence-based treatment through randomized trials that was better with PCBH in the mild to moderate population, which is most of the people who need help, versus the randomized trials that show medications and more traditional psychiatric treatment and severe illness.
Yeah.
I'm curious as to why the payers have not made it more easier to pay for PCBH in a primary care setting, because the randomized trials are clear and the risks are so much less with medications in that population, and really the cost to payers in terms of less medication, the cost of medications is a lot, much less all the visits. So do you have any insight as to why the payers have not made it easier to get PCBH in primary care?
Yeah, I think it's all about power, Patty. You know, and so, when we talk about power and tradition, we have a couple of things that are contributing. First, just the nature of research. I mean, historically, and we have a lot to kind of undo, the nature of research encourages people to kind of play it safe, go for, the effect, and not necessarily develop feasible kinds of interventions that are financially feasible, that can be measured in feasible ways. Lots of problems with that, but that's really changing with the implementation science. But it takes a long time to change healthcare. The other thing is drug companies. They are a powerful lobby, hugely powerful, and we don't have a behavioral science lobby. I mean, I think in our professional organizations, we're doing a better job of preparing people to get out there, talk with their legislators, take scientific findings, write brief policy statements on it, share it. But that's kind of like what we need to do and haven't done. Those are just two really brief thoughts. But it's starting to happen, and it just it takes time. Um, yeah, and then I think the third thing I would say about that is uh, primary care providers. Um, my friend Bruce Errol, and I, he's the one that I want to share his most recent publication on, but didn't have time today because it's pretty exciting. Um, he says doctors are in love with their medications and procedures. And, so, and they've been alone for a long time. So the tradition is siloed care. They're not used to working in teams, and they
Right.
don't know what we can offer. The other thing about that's really going to change things, I think, with payers is we now have um, all of the evidence on antidepressant medications. And if the payers are not looking at that, it's on them. So we know what it's only recently that all of the studies that were not published about antidepressants were released and are available and have been summarized. And if they're not reading about that, that's a problem. We need to, that's pretty easy to bring it to them. And I think you can do that in your area,
Mhm.
in your state.
And, as a physician and a psychiatrist, this really matters to me. And I know many physicians would rather spend time talking to patients and would rather be holistic and work with a team. But psychiatrists don't get paid for that. What people get paid for is what they do, whether they be primary care doctors who are paid on a volume fee for service basis, or psychiatrists get pushed to doing inpatient or 10-minute med visits. It's not that most psychiatrists prefer medications, it's just that's what we can get paid for. And so we are really taking the path less traveled by saying, no, as a psychiatrist, I am not a prescriber. I am someone who can prescribe, but I want to do more. And we need our payers to recognize that and to pay for all the types of services that can help. So I
I
so appreciate this.
I so agree, and I worry about job satisfaction for psychiatry. And one
Mhm.
of the visions I have that I think will be something that I think the government's starting to kind of see it too, because I see some grant possibilities or RFPs out there for like regional centers for children that are multidisciplinary. And wouldn't it be fun to work in that capacity to increase the expertise of people on the front lines? But you're sitting there, and Patty, you're not alone, but I'm in the room and some other people are in the room, and we're putting our heads together, and we're, you know, um, supporting people in the field. Yeah, that would be.
Yes. Well, I know we have a lot of people who are like-minded, and many of them are on the call today as far as folks in Arkansas. And even there have been people from out of the state on this call. And so we just have to continue coming together and sharing what we've learned. And it's really great to hear your experience and your path through this. And so thank you so much for sharing that. And we've had some questions that have not been able to be addressed. And so I'm wondering if we can set up a conversation later with a smaller group to address those perhaps.
Sure.
All right.
Good. Yeah. I grew up in Texas, or at least part of the time I was in Texas, and I did go to the University of Arkansas briefly. And I've done some PCBH training down there too. So
Yeah. Yeah.
yeah, yeah. Oh,
Great.
beautiful state. Thank y'all
Thank
for
you.
inviting me. I appreciate that.